Aloha. My name is Yoshihisa Asano. I am one of the founders of Noguchi Medical Research Institute. Today, let me introduce you the two doctors, Dr. Charles A. Pohl and Dr. Takami Sato. Before I'll introduce you who's who, two doctors, let me introduce you my friend and one of founders of Noguchi Medical Research Institute, named Joseph S. Gonera. He is Dr. Gonera. We call him the Joe. Joe is called the Pope of Thomas Jefferson University. He was Dean of Medicine of Thomas Jefferson University as almost 16 years. And now he is a director of Asano Gonera Center for Medical Education in Thomas Jefferson University. This is Dr. Charles A. Pohl. Charlie is the successor for Dr. Gonera. He is the most excellent professor and handsome professor of Thomas Jefferson University. And this photo means my long year contribution to the Thomas Jefferson University, and this photo shows the original ceremony for Asano Gonera Center for Medical Education. And let me introduce you Dr. Takami Sato. He is chairman of Board of Trustees of Noguchi Medical Research Institute for a long time. And he is managing the whole necessitated activity on Noguchi Medical Research Institute for 1 decade. One day, Charlie called me and he asked me he wants to meet someone very famous bureaucrat of the Japan National Art Museum. I cannot understand why he does want to meet the bureaucrat of National Museum. But I did it, and I have arranged the meeting among Charlie and bureaucrat of National Museum. This is the Ueno Park. This is the old museums in Ueno area. One is the National Museum, another one is the Tokyo Metropolitan Museum, and Gate of Hell by Rodin, and the Thinker made by Rodin, just in front of the Western Art Museum in Ueno Park. And you could see the right and down statue of Dr. Hideo Noguchi in the center of Ueno Park. And if you have a chance to see this statue, please pay attention to see under his feet. You could see the plaque, which shows the pro bono humani generis. It is everybody should have the humanism with love, or love with humanism to others. Dr. Hideo Noguchi's basic philosophy, why he does pay his whole life to investigate the pathology, and he died by the yellow fever in Africa. But through his life, he has kept the always pro bono humani generis in his life. Now back to the story between Charlie and me. So Charlie taught me why it is very essential and necessitated as the key issue So someone who learns the medicine should have the same sense to understand art in arts. Especially the pediatrician should learn the art before they should learn the know-how, technology, and science regarding the medicine and finally the pediatry. Charlie finally gave me the our basic concept and the philosophy how to manage the Noguchi Medical Research Institute as the foundation for the medical education and medical international exchange under the ideology or concept or philosophy, science and art equal. Generally, we have to say the compassion in medicine. Charlie advised us humanity and empathy in medicine is the most optimum basic philosophy for Noguchi Medical Research Institute, who are practicing the medical education and international medical exchanges. Okay, now I'll hand over Dr. Charlie. Thank you very much for everybody and everyone. Aloha.
Beautiful here. And it's really perhaps the perfect place to have the dialogue, these difficult conversations about important issues facing healthcare, our patients, our communities. And so I'm thrilled to be here. And as you can see on the slides, I have a picture of two beautiful ecosystems, the Diamond Head Crater and the Japanese Gardens. And when I say ecosystems, I'm talking about a community of living organisms, plants and trees, and animals living in harmony and rely on each other for survival. And if we look at healthcare and patient care and caring for the community, I look at that as an ecosystem as well. What I mean by that is there's a lot of different patient populations. There's many different parts of the healthcare team. There's different scientific advancements and different payers. And we need to make sure we keep a good balance so that we can ensure that we don't do any harm to the people in healthcare, our patients, and our community. So my goal for the remaining my time is I'm going to talk about the landscape of healthcare, talk about some of the disruptors that we face, and then talk about some of the strategies. And you heard a little bit earlier, but some of the strategies to ensure that we make sure that that ecosystem works well. I always say in the 35 years that I've practiced health medicine, there's not a more exciting time to be in healthcare. If you look at some of these pictures, today, our neurosurgeons at Jefferson in Philadelphia are operating in almost 50 hospitals across 5 states from a room in a building that's 2 down from where I sit in Philadelphia. Think about that. Today, I'm sure it's happening here, but at Jefferson, we're seeing patients rounding with the families and loved ones, whether they're in Philadelphia, whether they're in Chicago, Hawaii, or Japan. We're making sure that we are including the loved ones in the decision-making, or at least in the comfort to our patients. And what's also really exciting is now there's new technology where we're able to have patients engage with their own health, which is really exciting. But if you look at those 3 pictures, what we're starting to realize is through innovative technology, we're starting to get a little separated from our patients. And how do we preserve the human touch? So, oops. So I want to talk about some of the disruptors. And so innovation and how do we preserve empathy, as Dr. Asano was talking about early on in his introduction. There's also the disruptors of informal hidden curriculum that we all know. when we're seeing patients out in the community, out in our offices, we're doing home visits. It's the role modeling. It's the, unfortunately, there's things that are said or not said in the elevators or when we're with our patients that are really critical. I sat on the Philadelphia Youth Fatality Task Force as well as the Infant Mortality Task Force for a number of years. And you can imagine you have to die to be presented at those task force. Very horrific stories. Very horrific stories, but you can imagine the gallow humor by the Philadelphia coroners that are seeing this all the time. Is that appropriate? Is that the way to handle? But that is happening in healthcare. There's a hierarchy in healthcare and et cetera. There's personal challenges. I've had students come and tell me that they did a rotation at one of our affiliates in OB. They didn't get to catch a baby. The resident was rude and ignored her. And the attendings wouldn't give them a time of day. And we pay attention to that. And we've severed ties with some of our clinical sites. But 2 weeks later, someone came that had done OB at that same outside hospital. And the student said, this was fantastic. I'm going to go into OB. The residents are really nice. The attendings engaged me, let me catch 5 babies. It was great. And as we did the dissection of that situation, the OB resident had a miscarriage. There's things that we don't know when we're rounding and interacting with people. Public trust. People love their physicians. People love their nurse practitioners and their physician's assistants, but they don't trust healthcare. And so that is a challenge. And you can see fragmented healthcare. How frustrating for those of us in clinical practice when you're doing a home visit or you're in the hospital and you want to discharge someone to a different service. If you're at home, you want to get them into some kind of program for social determinants of health, or if you're in the hospital, you're trying to discharge them to a transitional care, a SNF unit. And how many times does it just not work? It's really a fragmented healthcare. Oops, I apologize. I keep hitting the wrong keyboard. I'm a pediatrician, so I'm going to remove that from my site. So I want to just look at some of these a little more closely, some of these disruptors. And the first one is there's a shift in the public and payer expectations. Patients expect high quality care at a very low cost. And I think that's very reasonable. I think that is exactly right. In fact, they want high quality outcomes, patient safety, bring value, so to speak. They want stellar patient experience at affordable costs. And Don Burrick, who was a pediatrician, once he coined this many years ago as the triple aim. And it's the right thing to do. But just so you know, when I was seeing patients last week, the children's hospital that I work for, they're evaluating my quality of care, making sure my patients that I see have a good experience and it's an affordable cost. I'm not ordering unnecessary tests. In fact, the payers, and we have multiple payers, the payers are evaluating all this and deciding how do we best get aligned in how we get reimbursed. So that's a little more complication. So I would argue that we really need to make sure that we have a nimble, engaged, integrated health system so that we can achieve that triple aim. And we'll talk more about us, our experience in a moment. Let's talk about the explosion. There's such an explosion of medical knowledge. So it means that we have to find new and innovative ways to digest, interpret, assimilate, and apply that information. And then let's talk about innovation. Let's look at the 1880s. We typically communicate with our patients face to face, and that's all you could do in the 1880s. How did you get information? How did you learn about the patient's care? Or how did you make scientific discovery? It was through observation, word of mouth. In fact, in the 1700s, or revolutionary time, you really, to become a doctor, you were apprenticed. Or if you were one of the 35 physicians during the Revolutionary War, you actually trained in Europe and you learned by textbooks. There was no patient exposure, and that was the expectation that we weren't looking at evidence-based. So you can imagine what that was like in the 1880s. Now, I would argue we've had innovations for a long time. And this is Dr. Lyneck, who really explains that. When you think of Dr. Lyneck, because of his spiritual and religious background, and also his working with a woman who was blushing because he was going to have to listen to her heart sound, which meant put his ear on her chest. He decided to just take this piece of paper, roll it up, and put one side to his ear, one side to her chest. And that was the invention of the stethoscope, as we know it. So innovation has been around for a long time. Now let's move to when I was a student in the early 1980s. We used phones. We did not have the internet. We didn't have smartphones. We used phones. So that changed. It was face-to-face, but we could by then communicate. We used books and journals. Journals would come once a month. And you can imagine the books that we learned from. That's all we had as medical students. And that was really based on information that was really 3-4 years old. We expanded our diagnostic decision-making to include laboratory testing by then, and we were using imaging. And the scientific discovery, we were using evidence-based medicine. So if we fast forward today, it's on steroids. We are using technology to use data analytics, data surveillance. We're using evidence-based. We're doing precision medicine. It's really exciting. But you can imagine for some of us, we weren't trained, and you're not being trained exactly in exactly what you may be doing when you're practicing in 5 years from now. So you can imagine it can be somewhat uncomfortable and disrupt our ecosystem. And in fact, we have a new field of digital health, and it's exciting. Digital health now is helping us with patient care, decision-making. It's actually allowing the patients to engage in their care. It's actually even changing patients' behavior. That's been well documented to really improve care. You can imagine how this is helping with diagnostic or scientific discoveries. It's just fantastic. But again, we have to be very comfortable with this, as well as we have to make sure that we don't get any untoward consequences. And to drive this point home, I'm going to give you an example of Open Table and how it disrupted the food industry. You can imagine when I found out from Gregory Skarnick that this was going to go on in the beginning of January, I got out my iPhone. I went to Open Table. I was looking at the different menus of different places. I was looking at the prices. In fact, I was looking at what people wrote about those particular places, and I just booked right there on the spot dinner reservations for a couple nights ago. And then 2 days later, I'm talking to someone saying, I'm going to Hawaii. And they said, oh, you got to go to this place. Open Table, discontinue that one place. And I went to Merriman's. It was as simple as that. It was fantastic. I love the transparency. I love the convenience. But you can imagine if you're a restaurant, what this means to you. You're being evaluated. Your evaluations, people can just cancel your table at the last second. And Uber is just another example of that. And talk about how far we've come. I kind of love this comment. In the 1990, we said, don't get into strangers' car and don't meet people from the internet. Now we say summon strangers from the internet with the sole purpose of getting to their car. And this I see with my two daughters because they grew up in around 1990 when we said, don't do that. And now they're the ones that taught me Uber, which again, I love, love, love. So again, we have to be comfortable with it, but we have to be cautious. And then I'll talk about the elephant in the room, COVID. It's been interesting the last 2 years. This has magnified a lot of the challenges that we're facing as clinicians as we approach. And I'm just going to highlight a few areas. Fear. I think what's been really interesting and not a good way is that we now have fear. I'm sure all of you have had COVID or a loved one who had COVID and probably knows someone who's died of COVID. Maybe taking care of patients with COVID. I'm a pediatrician. I diagnosed 2 last week in the office, the one day I see patients. There is that fear. especially Omicron, you could walk through a room and we realized it was spread a little different. We just didn't know about it. Patients are dying, and they're dying alone, which they've always died alone, but they're dying quickly. And that's what's different. I trained when HIV was coming out. First, we didn't know what it was. People got sick. And then they died in 3 to 6 months or within probably 2 years at times. And we didn't know what caused it. We were scared to touch patients. But now look at HIV. It's a chronic disease. We're very comfortable because we understand it. But with COVID, I think that's what's alarming is people are walking in, especially if you're unvaccinated with an underlying medical condition, and you will potentially die within the first 12 to 24 hours. That's scary. I think it's worth mentioning, we're all taking on special extra roles and responsibilities. What I do every day is very different than what I did 2 years ago. I still do what I did 2 years ago, but now I have a lot of added responsibilities. And isolation. We all go into medicine probably because we're very social, but isolation is a concern. And then uncertainty and ambiguity. I was talking to someone last night. I love ambiguity. I just think it's great. I love innovation. It's exciting, but the trouble is I'm over it. I think we all expected things to get back to normal. And I was talking to someone at the hotel about this. When they find out you're a medicine, you start getting asked a lot of these questions. But I think we're just tired of it. You know, in Philadelphia, we were making decisions where we're making different decisions what the state is deciding versus what the CDC is deciding. And that's just so difficult for us because the Philadelphia is so conservative. So the clinical enterprise made a policy on can you make a meet in a group with food, but the university didn't. Now the city today said they're going to allow that open up. It's just, you can imagine every day is different, which is interesting, but it's hard. And, you know, so there's a lot of stress to the system. And I look at a bowl, you know, when there's a lot of stress, what happens? It cracks a little bit, it can break. And why I mention this again in our ecosystem is, you know, there is challenges, but there's a silver lining. Again, there's no better time to be a medicine. I'll get to that moment. But when, as you heard about earlier, is there's a lot of stress that we're experiencing. So those of us in healthcare are experiencing this individual trauma, as the definition from the U.S. Department of Health and Human Services says. So there is some individual trauma. And I'm not sure if this was shared. I think there are different ways people experience or witness trauma, which is, I think, interesting. And the fact that you could have trauma individually, like if you get attacked or you're in a car accident. If you're in an affinity group, like you're a firefighter or in the military, you have a different type of trauma that you as a group can see. Communities can see trauma, gang violence, school shootings, and then mass trauma, such as the earthquake, the fires that we're seeing on the West Coast. There's all different ways, and we all have to try to adapt to these different traumas. And I think what's a challenge now is with the pandemic, it really transcends all these domains for us in healthcare. So we just have to make sure we prioritize us. So this is probably good after some of those stories that, you know, how do we manage and kind of adjust to some of these challenges you hear? And why it's important is there's a lot that trauma can do. And I think what's really important is trauma can really change how we view ourselves and how we view the world. And I think what's to me very alarming is how we view the future. So this is why it's important for us to prevent the trauma, or at least kind of buffer the trauma that we're with. And as we know, we all went to medical school or some health science, physical ailments, it can affect your immune system, your sugar control, cortisol levels, et cetera, et cetera. So it's really important why we have to prevent this trauma. I love this intensive controlling. This, you may have trouble with unable to embrace complexity, lack of presence. It can result in avoidance, cognitive overload, pull towards confirmation bias, away from critical. You can imagine those are not good things to lose if you're trying to take care of patients, your community, and each other. And then there's empathy, and I'll come back to that. And we talked a lot about the personal well-being, but just to emphasize some of the unintended consequences is, besides the well-being, it can definitely affect the culture. You know, when people say things that they shouldn't say with you around about someone that can really change the culture. Or if you have someone who loses a job and it really touches us. All of these go back to the well-being. Safety, we worry about patient safety. In fact, that's probably one of the major causes of mortality and morbidity in our country, and that's a talk for another day. But clinical errors, and you can imagine that us, even if we didn't cause it, it definitely makes us affect our personal well-being. And then retention. And when I'm negotiating strategies and budgets with the health system and hiring for wellness strategies, I always bring up retention because it's really a challenge. And again, it's just not good for our system. So that's how I'm usually successful. But at the end of the day, it really impacts our well-being. So where do we go from here? And I go to Japan a lot, and I love Japan. And I know Hawaii has practiced this, and so I don't know if it's in your curriculum. We use this in our curriculum. But there is this tradition called consigning, which looks at when you have a cracked or broken bowl, they will put it together using powdered gold. And the idea is it's supposed to allow us to embrace flaws. But I have a different interpretation. I look at kintsugi as an opportunity for us to restore our well-being or that ecosystem. In fact, even make it improve. I think if we do this right and handle some of the situations that you heard earlier. So the National Academy of Medicine, which is now called the National Academy of Medicine, came up with kind of a wheel and really how to look at well-being across the continuum, our patients, the clinicians, and that's the quadruple aim that you hear about because they left us out, the clinicians' experience and well-being, but now it's a quadruple aim. And this was published by Tim Brigham, a dear friend who's now works for the ACGME. And they were able to identify is there's many factors that go into our well-being. Some are systematic, the yellow, and some are personal factors, individuals, which are in the blue. And I think what's really important is not only knowing that there's external and internal factors, but we have to make sure that everyone knows this is a systems problem and we need a system solution, and we have to stop blaming all of us, our patients, the health system. I think it's important for us to just as a system to make sure, and so this is use your voice to make sure where you're learning, where you're practicing, that it's built in, that you acknowledge, access, and intervene. And that's a lot of the information that Tate Shenenfeld, who's one of the big physician burnout, but they've looked extensively on this, and some of that's in that Mayo Clinic proceedings. He's now at Stanford. Last week, the Healthcare Workforce Rescue Package was released, and you may or may not have seen it, but they came up with just 5 things to really help with all these disruptors. And this was really by the alphabet soup, the American Hospital Association, the AMA, and et cetera. And the one I love the best is they said, you gotta gross. And the students probably know this, the residents may know this, but get rid of the stupid stuff. They just put it right into their recommendations. And it is so true. How many modules do we take? And I do them twice. The educational models about safety and all this stuff, I do it every year. And I do it twice because I work at Jefferson, Thomas Jefferson University, but I see patients at the Children's Hospital. So they make me do it again. And I don't know, if I spill a chemical, I'm going to call the experts, or I'm not going to rely on my modules and electronic health records, et cetera. They really extensively brought this out. And we have to make sure the strategies are built in, not add-ons. And that's a challenge. We are constantly talking about that with our health system and our enterprise, the university and the clinical side, because we seem to want to cut costs, but we need to save that delta and put it back into the system to really address some of those concerns we have. You heard about trauma-informed care, so I'm not going to go into that, but one thing is just make sure where you're working and wherever you're working to make sure that we incorporate those 6 principles. I think every place you're learning and every place you practice needs a robust wellness program that really aligns with the needs or how the person is able to really adjust to what's going on, those micro traumas I was talking about. This is something that we published in the New England Journal this past year, even related to COVID, but it's hard to see. But if you see on the very bottom tier, if a student, a nurse, a physician, a staff member says, I want to learn how to be healthy and maintain our well-being during the challenging times, we have a really robust resource there. As you move up this pyramid, you might be saying, I'm experiencing stress in work and school and other areas of life, and that's where you need perhaps peer support. And at some point, you may get to the red, tier 4, and you have to make sure that you have the right therapeutics. But the goal is really the prevention down in the blue area. So now I'm going to just turn to the strategy of how do we preserve the ecosystem with all of that disruption. And I'm going to simplify it to 5 different things. First of all is empathy and humanities, which turned out to be the title of my talk. I hadn't realized that. But the title of the talk is Empathy and Humanities. I had a little, I changed a little bit. And I think that's a really critical piece. And you heard a lot about empathy and humanities from the previous speakers. Why this is important is we have done an extensive amount of research. We and many others have done this. And why is, I think, empathy the secret sauce? In fact, we were the ones who demonstrated at Jefferson using this empathy scale that we developed, where empathy goes down in your 3rd year of med school. And you probably have heard that. And unfortunately, it was replicated. But now we were able to show we can preserve empathy and actually improve it in med school. Thank goodness. And I'm going to show you how we do that. And we do that even for our practitioners. But why is empathy important? And this is well studied. A lot came from our institution was we can improve learner and clinician well-being through empathy. If you have more empathy versus someone who has less, you will make your patient will be more satisfied. That kind of makes sense. We've shown that emotional intelligence, empathy, you're more empathic, you'll show more emotional intelligence, leadership, and interprofessional collaboration. We work in teams, and that's critical to our success, so that's important. Clinical competence, think of that. You're going to be better. You're less likely to make those medical errors and more likely improve patient outcome. And this is what I love the most, clinical outcome. I always said, okay, your doctor's empathetic. I was being a little facetious. You know, so you feel good. Does that really matter? And this is the point that I love driving home because people listen. Payers listen, hospital administrators listen, educators listen, and this is how we get a lot. But we have shown, we did a study at Jefferson where we looked at people with metabolic syndrome. And if you were more empathetic as a clinician versus less empathetic, your patient had better HDLs. And the LDLs, their cholesterol control is better. Think of that. And this was replicated. We did a secondary data analysis in Italy with hundreds of thousands of people and demonstrated. And in fact, other people have replicated. And so it's really cool. So if we need to preserve that empathy, and we will make all those wins. And so just to summarize our approach at Jefferson is we really take this very holistic approach. To preserve the empathy because we know it's good for your well-being, and I just showed you why that's important. So we expect every one of our medical students, for example, and we're starting to do it in our GME, and we have one of the largest GME programs in the country, where we have required humanity curriculum. It could be that they go to museums. It could be that they're learning to drum. It could be that they're drawing from anatomy. There's something called the Mutter Museum, which has some scientific medical irregularities, and they'll go. So when they're dissecting the chest, they'll go and draw some of the deformities, perhaps, that we'll see. So it is required in our curriculum. We think it makes people feel better, but also we realize, like you, everyone that graduates is expected to have excellent knowledge and clinical skills. But we all know if you want to be successful in healthcare, you need the social intelligence. And we've been able to show and prove that we can really, through humanities, make sure when we have co-curricular and extracurricular, that we make sure that we can teach tolerance of ambiguity, comfortability with complexity, cultural diversity, and I could go on and on. We can teach bias, and we've shown all of that. And Gregory and I have had some really wonderful conversations, and we hope to explore more. And I give Dr. Asano, and I see that we have a couple of representatives from Noguchi you heard from earlier here, but Dr. Asano has just been amazing, and NMRI, Noguchi Medical Research Institute, have been incredibly supportive of this, as Dr. Asano said earlier, where they just really understand the importance of doctoring because of some of the evidence I showed you earlier. We have artists in residence. We have drummers that go to the bone marrow transplant unit and the rehab. And we're not only improving, we think, and we're showing the patients, but we're improving the employees, the staff that are working in these very high stress situations. So again, it not only makes you feel better, but it will improve your clinical care, your emotional intelligence, and you'll be better. And you can see we have many series. In fact, we even have the Dr. Yoshihisa Asano Humanities and Health Science, which we have about 200 students every year that complete the certificate. And so it's very exciting for us. The next thing for the golden repair, how do we make sure we buffer all this trauma and also recover, is take a breath. And it means really take a lot of self-care. And I want you to live in the moment. What some of you don't realize if you were Zooming is a lot of tech problems today. I lecture a lot of places all over. And what did I do when I came back with another computer and another slide deck is I just took a deep breath, whether it's the box breathing or whatever breathing. But remember to just take a deep breath and live in the moment. It really improves your well-being and improves your empathy. And I would argue when you take that deep breath and you're still feeling very uncomfortable, that's the time to talk to a friend or get help. So don't forget that. Gratitude and humility, self-compassion. It's really important that you show empathy to yourself. And you should develop a mantra. When you wake up every day, you probably should say, this is, whatever the one or two words are, it should be brief, it should be simple, and it should resonate with you. And create your own narrative. I think that's really important. Tate Shenenfeld, I suspect, has come to visit you here in Hawaii now that he's in Stanford. But he tells a great story where he came home. He's a medical oncologist. He came home one day and his wife said, "How was your day?" And he said, "Oh my, the electronic health record was broken. I had someone that didn't speak the language and we had trouble with the translation." It just is, by the end of it, I was like an hour and a half behind. People were angry. I was upset. It was emotional. He says, "That's a mistake. You should probably say, what great thing happened to you today?" And I tried it. My daughter used to, my oldest, who's in her late 20s, she used to always, all this drama, and she just, the lens she looked through this was 8 years ago. It was just like, it's like I just dreaded these conversations when we talked. But then we started to say, after I heard Tate, I said, and she does this to me, and I do it to my wife, is what great thing happened? And you can't imagine the fruitful conversations. Feel free to do that even with your patients. And so I think that's a really positive affirmation. There's a lot of things that can be done, and I know that they're well included in your curriculum. The other thing is who's on your team. And I think it's really important to surround ourselves by people that we like and realize, and this has been looked at in the trauma literature, it's shown, it's been looked at in healthcare, that it's really important to get a community around. And we have to be cognizant. I have another daughter who had a colonoscopy a few years ago. She has celiac disease and was just, I shouldn't say just, but she had a colonoscopy. This was back when she was 20, and she was a young 20. And because she was 20, she went back into the pre-op area by herself. They wouldn't let us in, my wife and myself. And my wife is a senior administrator at this hospital. So they wouldn't let us in. Finally, I think I negotiated, navigated, because I have a young, it's a very young, very frightened. And they let us back. And you have to realize my daughter's 5 feet. My daughter is fast and aggressive and would take you down. She played she played field hockey at D1. She played at the national level. But boy, she's tiny. She's only 5 feet. So here she is in this big bed. She's tiny. She has they have that little cap on. She has the blankets up here, and she's like shaking. Because my wife worked there, everyone came to visit just to say hi. So we had the GI staff person, the GI nurse practitioner stopped in, the GI attending stopped in. This was same in anesthesia. In fact, a friend of the family who's a plastic surgeon, I'm not even sure why she stopped in, but she saw on the schedule my daughter, so she stopped in. So we get there, and my daughter turns to me, I'll never forget, she said, I wish they gave me the roster of who's on my team. Remember, she played sports. And I thought, what a beautiful thing, because we just remember, we walk in all the time and people don't know who's on the team. But you and all of us, especially today, when I had technology problems, I started to realize in Hawaii who's on my team. It's really important to know that. And also important to know who's not on your team and separate yourself, because there are times you just need to care for yourself. And then the last thing, this is the last point, is joy and purpose. You have to find joy and purpose in your personal life and your professional life. And this has been really well played out in the literature with Tate Shenenfeld and many others. Every day you need to wake up and remind yourself the joy and the purpose. And that will really help preserve your empathy and preserve your well-being. I just want to kind of end with the joy and purpose. When you all came here into medicine in your white coat ceremony.
I'll move it. We can.
In the white coat ceremony. And you came for a reason. I want you to remember why you came. And I think it's important to realize that you came to take care for others. And don't forget that when you're dealing with the fragmented healthcare and you're dealing with perhaps a diverse patient population that have different values or cultures, we need to respect all that. And I think it's really important to remember that it's really special. As in when my father and grandfather practiced medicine, think about this. Every day, I get to wake up, I learn, teach, and care for patients. And that's truly an incredible gift and privilege. And as in Hamilton, the psalm that said, you're in the room, we are in the room. It's been no less important. In fact, it's been the most important the last 2 years, where the world is turning to us for comfort and safety. And what an amazing thing that is. So at the end of the day, you're in the room, you're helping make miracles happen. You're helping people die with dignity. You have the ability to connect them with the right resources, which will really preserve that ecosystem. And again, we want to preserve that ecosystem so that we can make sure our patients are well, we are well, and our communities are well. And so again, I thank you so much for this real privilege to spend part of your afternoon with you. And you know, I don't know if we have time for a question or two. Yes.
Question or Corey Joe on, is there anything in the chat?
Yes.
I really appreciated your focus on the history and kind of how we're going forward, and it felt, sorry. Thank you. It felt to me like you were kind of laying a groundwork for us moving forward, and I'm curious
I think that COVID seems to be kind of this turning point of this reflection of how we move forward. And I'm curious, this may be a loaded question, so take your answer with a grain of salt, but if we don't move forward COVID-wise, how do we incorporate this, or how does the plan change? Or what's a different future if things don't move forward with COVID and get back to, even though it's not an old normal, but a new normal, if we're kind of sitting in this space of the pandemic? I'm curious how this model works and if you would change it, and just your thoughts on that.
It's a great question. Hopefully everyone heard it, and I don't know if I have the answer. But again, what brings me joy and purpose? COVID is bigger than us, but patient care is bigger than COVID. So I step in every day. If worst case scenario is if we deal with COVID, and just so you understand, I'm dealing with COVID. I'm in charge of the 8,000 students for this past 2 years at our university, and I sit on the daily calls for the clinical pillar, and I meet with the city every week. And every day we're dealing with it. It's old, but again, remember to create that narrative, because just think of the impact we're having. Think about how far we've come in the 18 months and some of the wins we've had with COVID. There's been some real wins, like Zooming. I'm not a big Zoomer. I'm pretty good at it at this point, which I'm not proud of. But there's ways that we can be more effective and efficient. And in fact, it's really great for some of the patients. In fact, we have people that are doing telehealth in this room. And I don't do much telehealth. I've been in person. I took about 4 weeks off. The Children's Hospital slowed down, and then we quickly got back hands-on for various reasons. But at the end of the day, I think we've learned a lot that patients really embrace the telehealth. In psychiatry, it's really an interesting. In fact, we published some years ago a telehealth in the health science students in colleges. And it was really early. It was a pioneer work. And it became one of the most read articles during COVID. And we showed that people, kept their satisfactions. It doesn't replace touching a patient in the hands-on, but it can add that. So back to you is, remember why we went in, and learn. That's where the humanities can help us, because we can learn tolerance of ambiguity, we can learn design thinking, and we can take care of patients with all these evolutions. So I don't know if that quite answered, but I think again it's an exciting time, and I think our health systems are going to have to adjust. It's the quadruple aim. We have to make sure that we care for the whole ecosystem, because at the end of the day, we have to live in harmony. And I think COVID or not, again, I saw HIV. I saw SARS. I've been doing this, not as long as Dr. Sato, but I've been doing this for a while, and things come and go. And, we learned a lot about ventilation during COVID. Vaccines. I used to do vaccine research back when I was at Pittsburgh Children's many, many years ago. And look at how fast we got vaccines out. I don't think they're ideal. They're not sustainable, but there's some in the pipeline that we'll be giving once a year, or maybe, once or twice in your life. So that's where exciting. And I think, again, remind what you went in, because it's improving quality of care, it's reducing errors, it's bringing value, patients are enjoying it, and we enjoy it. So, thanks.
One more question over Zoom that Hi, so the Zoom question is from one of our medical students. What are some ways we can advance systemic change in healthcare? Would physician unionization be a viable option?
That's an interesting idea. I'm not going to be political, and I'm not sure about unionization. I'm not sure that I won't speak to that. But how do we? We need to have a voice, and that was talked about the last. I always say we have to really speak to those who don't have voices, and so I think it's really important to look out for one another and to make change. And I find that our most successful changes are coming from our students and our residents and our young faculty, because they're not afraid to speak up and use their voice for especially the patients, the communities. Whether it's climate change, we have a new organization, whether it's Black Lives Matter, and I could go on. There's so many rich stuff that we're learning from our younger generation. So at the end of the day, I think we need to listen and hear everyone's voices at the table, especially the younger generation. So thanks so much.